Thank you, Andrew, for the introduction, and thanks to Carrie and Nicole for involving me in the project. I'd like to recognise their commitment and passion for this project, which has been quite incredible, and for the making my involvement so easy in terms of the organisation and um, arranging for events to occur. I'll just begin. So I've not done a PowerPoint presentation. I'm trying not to use them anymore. So I'll just reflect on my involvement in the SPIDER project. And I'll begin by introducing the Dual Disability Service for those who aren't aware. So we're a specialist mental health service established in around 1999 in recognition of the gaps in mental health care for people with intellectual disability. And the aim of our service is to enhance the capacity of Victoria's public mental health services in relation to intellectual disability mental health. And we do that by providing assessment for consumers of area mental health services, and then providing consultation on treatment, planning and training for mental health clinicians. We were initially approached by SPIDER to explore concerns around mental health care for people with intellectual disability. And the current philosophy really is that people with intellectual disability have the right to the same mental health services as everyone else, although they might require additional support to be able to do that. And I think Robert mentioned the concept of reasonable adjustments in the previous presentation, and what we recognized fairly early on is a lot of these reasonable adjustments just weren't occurring. People with intellectual disability weren't able to gain access to mental health care that they required, and there were a range of barriers that explained that difficulty accessing those services. Not least was the lack of knowledge and expertise of mental health clinicians, people working in mental health sector, about intellectual disability in general. There's no real training in undergraduate qualifications. There's very little in the postgraduate education available, and many mental health clinicians lacked contact or experience of working with people who have an intellectual disability. And there tends to be this process whereby people with an intellectual disability and their families or carers approach mental health services seeking support, often in serious need of supports, and are then turned away with the comment that their problems are all related to their intellectual disability, or that term that it's behavioral, somehow conveying that all their what they're experiencing can be explained in terms of their environment or learned experiences. And that was leading to a lot of people who had genuine mental health concerns being turned away from mental health services and supports. And it quickly became apparent that there were major barriers across the whole continuum of care, from primary care through the specialist mental health services, and that the barriers existed across the whole service system. We did identify a number of specialist services, but these services really are very fragmented with limited collaboration, and have almost been set up in a way that they operate as almost independently of each other and the wider service system. So, for example, we have the Victorian Dual Disability Service, which aims to support specialist mental health services. We have the Centre for Developmental Disability Health, which aim to support primary health. And then we have a range of other services, such as the mental health intellectual disability services, which are located in the Alfred mental health area and Monash mental health area, and the transition support unit. So a lot of specialist services, but very small, isolated services with limited connectivity. And that really isn't in the best interest of people with intellectual disability, who need a holistic, whole of service response to address what are considerable mental health needs, most of which remain unmet. So in keeping all those considerations in mind, the Victorian Dual Disability Service and SPIDA engaged in a range of collaboration and consultation to try and look at ways of addressing those huge gaps and needs. And what we looked at was providing some, we're involved in a survey of health professionals' knowledge and attitudes in relation to intellectual disability, mental health. VDDS provided a range of training inputs into the ECHO series, which we felt were very well received. But one of the findings and one of the things that was reported as frequently being a problem was that health professionals were saying the information they were receiving wasn't allowing them to be able to effectively identify and recognize when someone did have a mental health problem that needed treatment or management. So the information they were receiving wasn't fitting with the types of the information they required in terms of patterns of signs and symptoms that it would allow them to identify, well, this is definitely a mental health problem and this person needs treatment, or they need to be referred on for more specialist assessment. And so there was a major disconnect between the types of information being received and what clinicians were seeking to allow them to make those decisions. So I think what triggered then the next stage of that involvement was Kerry approached me seeking information about what screening instruments or methods may be available to help in allowing people to more effectively communicate their distress and their problems to health professionals, to allow that that next stage in terms of deciding how to help people in the best way possible. And we looked through a number of different tools and assessments and decided there wasn't really very much out there that was that good. One of the things we did identify, though, was the and really this was based on my involvement with a project 20 years ago, whereby the Department of Health and Human Services had contracted Steve Moss to train BIST team clinicians in using the mini PASAD instrument. And so quite a significant investment was made in bringing Steve Moss over to Australia from the UK, training up BIST clinicians in using this tool. But it never seemed to have been used. It was never effectively rolled out, and there seemed to be never much investment made in continuing that project to allow it to be effective. But what I thought was that this seemed to be quite a good instrument to use, particularly the PASAD checklist, which was designed for carers and families of people with intellectual disability to identify and report mental health issues. And so we approached Steve Moss and had a number of collaborations and discussions with him. He was initially quite reluctant to get involved. And I think Kerry did a lot of persuasion, and we eventually managed to get his engagement. What he'd identified, though, is that when he'd undertaken training previously, this had generally been for professionals who had an underlying understanding of mental health. And so he identified that for any tool to be effective, the people administering it would need to have some basic understanding of mental health. And that led to us developing, in collaboration with SPIDER, a training curriculum that covered a range of key topics that Kerry has previously discussed. And so the VDDS collaborated with SPIDER in developing the training curriculum, and we've delivered that. That was included a range of webinars on a variety of topics in relation to intellectual disability mental health, and also a face-to-face training workshop that we delivered in Ballarat. There was a very good level of engagement. VDDS provides training and education for mental health clinicians on a regular basis, and we tend to have quite a large difficulty getting people to attend. We often have a lot of registrations, and when the time comes to deliver, not many people show up. There was very good attendance at all the webinars, and the face-to-face workshop, I've got to say the participants were really passionate and engaged in that workshop, which was predominantly aimed at a deeper examination of assessment, mental health assessment for people with an intellectual disability. And I think that based on the feedback and the engagement, there are good grounds of continuing that education provision should the sufficient funding be available to do that. And we would strongly advocate that education's rolled out across the state. So some of the issues that arose during that training that were highlighted were the fragmentation and complexity of services in the system, and how could people with an intellectual disability and their families possibly be expected to navigate the highly complex and fragmented service system that currently exists in Victoria. It's really hard to navigate this system. The lack and increasing difficulty accessing private health options, which are becoming very scarce. Difficulty accessing mental health supports across the whole service system. Continued siloing of services, whereby people say that, well, this is due to an intellectual disability and therefore it's NDIS problem, or this is due to a mental health and it's clearly not our problem, this is for mental health, and people falling through the gaps in services, which is still occurring. The lack of knowledge and expertise about intellectual disability health, both by mental health clinicians and across the whole service system. There's still a high degree of exclusion and discrimination occurring, and people are excluded from services on the grounds that they have a disability. And the lack of specific policies, guidelines or pathways. Even until very recently, there was an absence of intellectual disability content in most mental health policy or legislation. And still today in local mental health service policies, guidelines or pathways are absent in relation to intellectual disability. So following the completion of this training, the training was delivered by Steve Moss, who's developed what I think is a really well designed adaptation of the Moss Pass checklist, which is the update of the PASSAD checklist, to allow it to be administered by primary health clinicians and providers to obtain a very good description of mental health signs and symptoms, and for those people who are administering it to develop an initial formulation about mental health that can then be used to determine whether someone might need intervention at a primary health level or need referral for more specialist assessment and management. And I think it's a really good tool. We now have a good, well-designed tool and a well-informed workforce to administer it. I think the key now is to increase the number of people who are able to use that instrument, because I think there's a very big risk that it would go the way of the previous training delivered 20 years ago, whereby if it has insufficient support, it will just disappear and not really be well used. So I think it needs to be ongoing. There needs to be ongoing funding for this initiative. I think there needs to be sustainable. There needs to be a locally trained trainer for the checklist. And I think we also need to consider additional training in terms of the MOS Pass ID, which is then semi-structured informant-based assessment that could be administered by mental health nurses and GPs based in practices, to sort of so that the checklist would be the initial aspect, then maybe the mental health nurse or the GP could use the more developed the more advanced tool to further work up the person, and that would then lead to very well informed referrals to specialist mental health providers. The other thing that needs to happen is mental health clinicians need to know about the instrument, or they'll just dismiss it. So there needs to be training rolled out to mental health services, which would be fully within the remit of our service to deliver that. And I think finally there needs to be establishment for some forum whereby those people who have received training and those people who have been trained in this instrument can get together to develop and maintain inter-rater reliability and use of the instrument they've been trained in, to provide a level of peer support and review, and to improve interagency collaboration and collaboration between service providers. And so that's a very brief review of our involvement with SPADA. Again, I'd like to thank Kerry and Nicole for their involvement and making it so easy to be involved, and for their passionate advocacy for people with intellectual disability who have additional mental health needs.